just as we hear, depression and medical students, residents and impact. You think this place will be packed out because I know this is a very relevant subject. Dr. Schwenk has a background in the University of Michigan. Indeed, wound up serving as professor in the Department of Family Medicine and also vice president division of health sciences, and is the dean of the University of Nevada School of Medicine in Reno. And it's fascinating the way he explains the division between Reno and Las Vegas, but Reno is not Las Vegas. Very different part of the state and very different ethos around that school. But Dr. Schwenk, I have learned, is into fitness. He's already had his workout for the day. And if anybody wants to challenge him to that, I'm sure he'd be glad to take you up on it. He has served many places as visiting professor, showed his widespread interest from Cleveland Clinic, and the Department of Psychiatry also at Cleveland Clinic, and family medicine at Tufts University in Boston, and also in Ghana, College of Physicians and Surgeons in the country of Ghana. So he's an international spokesperson and physician. He is also serving as the vice chair of the Section 8 Institute of Medicine, National Academy in Washington, D.C. So he's very much involved in the national standards that deal with academic medicine. Depression and suicide. He's also gotten into sports, especially studying the pain and depression of retired professional football players. And did the same approach to studying in Ghana. So he is also a volunteer physician. He has not forgotten the obligation to those who cannot afford or who do not participate in mainstream medicine. So he's a volunteer physician among migrant farm workers. Was in Michigan and also now in Nevada. Migrant workers are found all over the country. He is speaking to us today on the subject of depression in medical students. And part of the problem with depression is how hard we have to work and how little we're able to control that impact of depression on our own mind. Because we're sometimes our own worst enemy for depression. Well, we are delighted to have Dr. Schwenk here, and we will hear him gladly. And we try to help us better understand ourselves and the issues facing us. Welcome to the University.
Thank you. Thank you. Thank you, Dr. Simmons, and thanks to all of you. It's a great honor to give the Gheens named lecture today, but I apologize for bringing a somewhat provocative topic and what you, I think, will find to be some disturbing data from some studies that we've done in the past. And I'm also going to comment that eventually I'll get Dr. Simmons to pronounce the name of the state correctly. It's Nevada. Nevada. You have to give up all of your language training and your good breeding and say Nevada, because that's the way we say it out there. So thank you for that introduction. Way too generous and embarrassing, but much appreciated. So I'm a family physician and have practiced actively throughout my entire career. Most of that is at Michigan, although I trained at the University of Utah after medical school at Michigan, and I practiced in Park City for several years before going back to Ann Arbor. And during that time, I developed an interest in depression and mental illness in primary care and in the practice of family medicine. Psychiatric disease is very common in primary care and something that's embedded frequently within the general medical care that we provide. So that led to many, many years of study related to depression in primary care, how it presents, how family physicians deal with it, how they treat depression. And I was giving a presentation one day several years ago to a group of family physicians, which I did a fair bit. And afterwards, a woman came up, a family physician from northern Michigan, and she said, well, that's all good, but she said, you need to study depression in physicians. Kind of got right in my face. You need to study depression in physicians. I said, oh, okay. And she didn't say much more. She said she's in a small town. It's a huge problem. It's an untouched problem, an uncovered problem, and nobody will talk about it. Physicians who are depressed have great problems seeking care, receiving care. They're stigmatized. She said, you need to study that. So that's how I got into this. And that led to a couple different studies and some follow-up studies that are underway right now. What I'm going to do is to give you a little bit of an overview of the topic and what other investigators have done, and then show you a couple studies that we did in Michigan before I left. We're continuing the work in Nevada. I'll tell you a little bit about that as well. This is what medicine looked like in 1949. Happened to be the year I was born. This is a very famous article in Life magazine. A photographer followed this family physician around for several weeks in rural Colorado and just looked at his life. And I think what you see is a life of great stress. The physician is sort of embedded in the community, kind of part of community life, fairly lonely. You can't see the picture in the middle much, where it says country doctor, but it shows him sort of trudging across the landscape, carrying his black bag. Very, very stressful. This is what medicine looks like today, with strikes and paperwork. This is a faculty member in the office at the University of Michigan. And in his defense, I'll tell you that this is not his office. He just sat in for me for a little picture. And I won't tell you whose office it actually is, but I will tell you that it actually looks like this. And generally piled up, lots of paperwork. Medicine has changed dramatically, much more demanding, much more stressful, many more ethical dilemmas. But the difference between this and this is not so much the same with regard to physicians and how they cope and how they deal with a very demanding life. I'm not actually interested in the differences here in terms of how medicine is practiced or the stresses of being a physician. And I'll tell you why a little bit later. I'm actually more interested in what it's like to be depressed as a physician, irrespective of what being a physician has to do with that. But I do want to cover some of these issues, which is the risk of depression and suicide in physicians, look at the issue of burnout and depression in medical students, look at the issue of how being depressed affects a physician's status, how it affects their professional status, licensing issues, medical staff credentialing issues, how they're stigmatized in their communities. And that takes us then to the study we did at Michigan a couple of years ago, which was published in JAMA a couple of years ago, on medical student attitudes about depression, and then look at some possible solutions. So again, it's not so much the issue of the stress of being a physician, the demands. Lots of jobs are demanding, lots of lives are very stressful, and I almost think that to talk about the demands of being a physician somehow lessens the importance of identifying depression and dealing with it properly in physicians. It's almost like an explanation. It says, well, of course, you know, you're depressed because you have a very demanding life. Well, lots of people have demanding lives, and lots of people have stressful lives. And I don't want to discount what it means to just simply be depressed and to have mental illness like everybody has mental illness, and to have to deal with that like everybody has to deal with that. There are some special issues, however, that cause physicians to be stigmatized in that regard, and that's kind of where I'm going with this. So I want to start with a case study, which is the way all good presentations start. This is a 48-year-old male family physician. Had a history of recurrent and chronic depression during medical school, several relapses over time, and became quite treatment resistant, had increasing difficulties. He had one prior suicide attempt and some significant health problems to go with that, and then got into some peer review and some medical staff problems. His response, which is true for most physicians, something I'll show you a little bit later, is that unlike most patients who are depressed who have more trouble at work, more absenteeism, come late, leave early, have more trouble, physicians actually try to work harder. We're a weird breed. And we think that if we just buckle down and work harder and try to work our way out of this, that we can master this just like we master so much of the rest of our difficult life. And this physician got increasingly discouraged and hopeless and helpless. This physician is the husband of the woman who came to me during the medical meeting. And I want to read to you bits and pieces of an essay she wrote, and she has given me permission to do this many times because she wants this to get out. She's writing about her husband. He was a respected family physician in a small northern Michigan community, had practiced in this community for 20 years, delivering babies, taking care of several generations of families. We were married, partners together in practice, along with 3 other family physicians, and had 3 children together. He attempted suicide first in 1997. He had been very depressed and anxious for several weeks and had been seen as a psychiatrist. I called the on-call psychiatrist one weekend when he really scared me. The psychiatrist started Doug, that's her husband's name, on lorazepam along with his antidepressants. One day, his day off, he was home alone, the kids were in school, his anxiety was very bad. He called the psychiatrist who told him to take more lorazepam. He took 7 1-milligram tablets, and when he couldn't calm down, he took 50 50-milligram amitriptyline tablets. I found him unresponsive, and he was on a ventilator for 2 days. His psychiatrist's first words to him when he woke up were, "You pimped me." He remembered his first serious depression at age 10. The next episode he remembered was during high school. We met during medical school. He had one significant episode during that time, but I didn't think much of it at the time. We were all a little depressed during medical school. Doug recognized his depression because he'd been dealing with it for most of his life, but I'm not sure he took it as seriously as I should have since we were all so stressed. He started seeing a psychiatrist during residency training. I felt that during all of his treatment, most of the professionals treating him did not take him seriously. I remember once when we tried to get him admitted for depression in the late 1980s, they sent him home and told him he wasn't, quote, that bad. He was a little bewildered by that response. In August, he became very depressed and suicidal. He had his plan all set. He told me about it, and I contacted his psychiatrist. He was admitted to an inpatient psych unit. I felt that the admitting psychiatrist made the best evaluation of Doug he had ever had. I asked the psychiatrist if Doug was working too hard, if this was contributing to his depression. The psychiatrist thought and said, "I would be afraid to take that away from him. Sometimes I think that work is the only thing that keeps him holding on." After Doug was released, there were significant problems with our 3 partners about coverage when Doug was hospitalized. We felt like they were blaming him and that they believed he had purposely contributed to his hospitalization for depression. One partner had to cancel his vacation to cover Doug. The partnership dissolved shortly after that. He was finally back at work, seeing patients, seemed to be doing well. Then a peer review action was initiated against him at that local hospital. The source was never identified, but this woman believes that it was their former partners. It alleged that Doug was impaired, referencing 2 cases more than 2 years old. As far as I know, the medical staff committee could not substantiate any evidence of impairment or breach of the standard of care. Yet he was still put on probation and had to be monitored. Every 3 months, the executive committee required a letter from the chiefs of medicine and of surgery, as well as from his psychiatrist. He was compliant with his monitoring, his medication, his appointments. He felt that he just needed to get through the year and that monitoring would be lifted. He said he was afraid to talk to a psychiatrist now that the psychiatrist had to report to the executive committee. He also seemed more floating and detached. The kids noticed he was more irritable. When he became more depressed, I made another appointment with the psychiatrist. He said 2 things to me. The first was a question: what are they going to do for me, Lori? He said, I didn't know what to say. Then he said, I look around me and everything is good. I don't know why I am like this. He had an appointment with a psychiatrist on the following Tuesday. He committed suicide the Friday before that. The suicide note to us said, I could no longer take care of you. He took 100 milligram amitriptyline tablets they had filled that afternoon under a different name at a pharmacy that didn't know him. I think the story is pretty powerful, and I think it demonstrates a lot of the points that I want to make here in terms of the way physicians experience depression, the way they're treated when they're depressed, the stigmatization that results, some of the medical staff issues, very intrusive monitoring that we do not do for other types of medical conditions or medical diseases. The difficulty seeking care, the difficulty obtaining care from psychiatrists who are your colleagues and your friends in a small medical community. This woman made the point that a lot of this has to do with smaller communities where physicians are known and their care is organized within that same community, causes great problems. I'll show you some of the consequences of that with a study we did in a little bit. So think about these questions a bit. Does being depressed have anything to do with being a physician? Does being a physician have anything to do with being depressed? Do you know physicians like this? How could you help a physician like this? That's where I want to end up. I'm going to take you on a little tour of some outside data, some of our own studies, and we'll end up back at those questions. This is a pretty well-known study, just one of several, about 1,200 medical students, 6 schools. Response rate very poor, less than 30%, less than 10% for third and fourth year students. Third and fourth year students are very hard to study as our residents. They scatter, they're on rotations, they're busy, they don't respond to such things. It's very hard to do work in this field because of response rates. But given these numbers, prevalence of positive severe depression scores about 14%, which is typical. That's a pretty typical number. It peaked in the second year in this study. Prevalence of suicidal ideation, 6 to 7%. Interestingly, peaked in the fourth year. Many people think, well, you know, you kind of get more and more stressful, get into the second year. Third year is very demanding, call, lots of stress. And then fourth year is supposed to be better, easier. But the suicide rate continues to escalate. We found that as well, and I'll show you that. And as is true for almost all depression studies in all populations, women always more prevalent than men. This is a more recent study about burnout and professional conduct. About 2,700 medical students, 7 schools, much higher response rate, much better study in general. Prevalence of burnout, 53%. This is an interesting construct. This author and this group does a lot of work in this area from the Mayo Clinic, and they are really focused on burnout as opposed to depression. There's obviously significant overlap, but I'm not, again, so interested in burnout as a transient phenomenon related to the stress of school or residency or being a physician. I'm much more interested in what it's like to have depression and, by the way, be a medical student or physician, irrespective of what the, quote, cause is. And this gets back a lot to this issue of depression as a comorbidity. So we talk a lot in medical practice about depression as a comorbidity for chronic medical disease. And quite often, physicians will discount depression in a patient who has cancer, for example, or a patient who has heart failure, a patient who has heart disease. And they'll say, well, of course the patient has depression because they have cancer. And it sort of diminishes the importance of the disease. It suggests that it doesn't really need to be treated, that you really need to focus on the primary medical disease. And the analogy I frequently use when I teach about this is it's kind of like walking into the emergency room and seeing a guy laying on a stretcher, clutching his chest, sweating, tachycardic, clearly having a myocardial infarction, and saying to the patient, well, of course you're having an MI. You're obese and sedentary and smoke and have diabetes and have high blood pressure. Who wouldn't be having an MI? And turn around and walk out of the emergency room. And we don't do that, but we do that with depression. And I think we do that with depression in physicians. And we say, well, what do you have to be depressed about? You have a wonderful life, you make a lot of money, you have a great profession, everybody respects you. Kind of discounts the importance of depression. That's my issue. But this study at least looked at burnout and looked at the relationship of burnout to unprofessional behaviors, found a significant association between the presence of burnout and students more likely to cheat on an exam, to take inappropriate credit for something that takes place during their clinical training, or to lie about findings, and a lower level of altruism. So somewhere in there, there's a connection between burnout and depression, and this is just another little view of that. There was a big meta-analysis a few years ago of all the studies of medical student mental health, 40 studies, almost all of which were at a single school. That's a big issue. Higher overall psychological distress and other mental illness related to an age-matched general population. Prevalence of depression, as we've already said, sort of in the mid to high teens. Risk higher in women, higher in unmarried students, higher in students with children, higher in minority students. What you take from this is that the students who do best in medical school are male, married students without children, which, if you think about that, is what medical school looked like. If you go down the hallway here, which direction? That direction. And look at the composites, you get to about the early 80s into the late 70s, and the classes suddenly become all male, or close to all male. And that was where the transition took place when women started coming into medical school. And what we've done is to subject women to a very toxic environment. If men were smarter about this, we would have realized how toxic it was, but it took women to sort of tell us how destructive this environment was and how women have much higher difficulty with some of these issues than men do. And a much higher rate of excessive alcohol use, again, particularly in women. More students are coming with a past history of depression. That's part of the issue. So there's more treatment. Students come in with a past history who might not have come to medical school in the first place. And here's the big issue that is very discouraging, which is that educational interventions have little effect. There are lots of things that have been done. And I'll show that in a second. This shows a little bit of the work on barriers to mental health care. Medical students all have access to health care. It's required by the LCME. The access to mental health care has to be private, confidential, separated from the faculty. You have to receive mental health care from mental health experts, psychiatrists who are not part of your faculty. There can be no connection with your educational programs. It's supposed to be available, it's supposed to be accessible, it's supposed to be confidential. Students don't use it. Horribly low rate of use of mental health services. So again, UCSF medical students, many positive for depression with the Beck Depression Inventory, very few using mental health services. Lots of barriers, lack of time. It's not lack of time, it's issues of confidentiality, stigma. And these days, probably not even cost, because most students have good access to that. This is a big one, fear of documentation on the record. Most students are very anxious that this gets documented, that it will compromise their residency applications, and that just carries through. So residents are fearful of this with regard to employment. Physicians are fearful of this with regard to medical staff credentialing or licensure. It just keeps rolling. This is just a kind of a laundry list of things that have been done to try to improve the prevention and treatment of depression in medical students. As we already noted, confidential psychiatric care. There are lots of mindfulness, wellness classes, mind-body classes, lots of ways to try to improve students' sort of psychological insight. Duke did this anonymous online posting and screening, but of course they also monitored it to look for really severe suicidal ideation. UCSF did something called stress rounds, again, mindfulness and self-renewal. Michigan does a thing called White Coat Blues, which is a little bit like Duke's online postings, kind of a place for students to anonymously talk about the stresses of school. Monash, which is a good school in Melbourne, Australia, did some performance enhancement. This is kind of interesting. It was thought by Monash and some other schools that instead of going at this as a, you are sick, you have a mental illness, we need to help you, they went at it from the standpoint of, we need to help you so that you are a better doctor, so that your performance improves, so that your performance is enhanced. It's an interesting twist as a way to get at medical students and physicians who are so driven and so task-oriented and so such overachievers that they get at their mental health care by telling them that this will make them better doctors. This is what some students do. Got that feeling of total depression, you need a shot of red eye. A lot of alcohol abuse and binge drinking in medical school. This is one study in residents. Residents are extremely difficult to study, really hard to pin down, really hard to get response rates. There's almost no data about residents. This was a study of internal medicine residents, did a quality of life assessment. 15% said quality of life was somewhat bad or as bad as it can be. Again, overall prevalence of burnout, about 50%. Interestingly, the risk of burnout was higher in U.S. grads than international grads. A lot of people speculated about what that means. If international graduates are more thankful or just prepared to work harder or better able to cope in some way, but there's a definite difference here. Quality of life scores were correlated with in-training exam scores, and debt was correlated with risk of burnout and risk of in-training services. So this was just a little touch on kind of what the life looks like in internal medicine residents. move on to physicians. This is probably the largest and most frequently cited study of women physicians. It was a nationally representative sample of about 4,500 U.S. women physicians. Nearly 20% reported depression, 1.5% had attempted suicide. This is a very shocking number, I would suggest. Increased risk with an environment of sexual harassment, interpersonal violence, cigarette smoking, alcohol abuse, family history. And here, if women were single and no children, meaning no social support, they were more at risk for depression. So here's where it ends up, which is the epidemiology of suicide. It's generally quoted, frequently cited, 250 physicians commit suicide each year. The number is actually probably quite low because of either accidental or purposeful miscoding of death certificates. And I've done some work with one of my former fellows, now junior faculty members at Michigan, to look into reporting of suicide for physicians. And it's pretty clear that a lot of suicides get labeled on death certificates as accidental overdose. The stigma kind of persists into death, actually, that to actually code a suicide accurately is difficult. But in any case, it's several hundred physicians per year. Suicide risk compared to the general population is increased moderately in men, dramatically in women. So as you know, the risk of attempts is greater in women, the risk of success is greater in men, in the general population. What we've done in medicine is to actually flip that, so the risk of suicide is greater in women physicians than in male physicians, which basically brings it to roughly equal. So we've brought women up, if you will, to be more likely to be successful in committing suicide. This again is the meta-analysis for where some of these numbers come from. 25 studies, mostly European and North America, and the ratio of suicide rates in the physicians to the general population, what we've just talked about. These are the typical factors, not different necessarily from risk factors for suicide in the general population. There are some specialty-specific issues. Anesthesiology and emergency medicine are frequently quoted, mostly because of access to drugs, comfort with drugs, ease of using drugs. So there may be a little more access, but it's not clear that there's anything special about anesthesiology or emergency medicine in terms of prevalence of mental illness in general. Physicians in general neglect medical, psychiatric, emotional needs. We are in general self-critical during adversity, so if we have troubles, if we have difficulties, we generally blame ourselves. We take on responsibility for our performance. And again, being single and no children, especially for women, is a greater risk. So that took us to this study. This is just a little study that we did to kind of get into this business. We did a survey of physicians in the Michigan State Medical Society. It was a really hard study to do. Well, for two reasons. We had trouble getting permission from the Institutional Review Board, the IRB, to do follow-up of non-respondents and to do reminders and to do postcards and to do the usual things that you would do with surveys to get a better response rate. And the IRB didn't exactly say no, but they get real touchy around studies of depression and suicidal ideation, which I think personally is fairly ridiculous. We think nothing of approving studies in which we give drugs known to be lethal to patients for various chemotherapy or cancer treatment trials or other sorts of things, drugs that have unbelievable adverse effects, known adverse effects, but we can't ask a question about depression of physicians. Seems a little strange. But the other issue is that we did some focus groups and talked around with physicians in the state and got the sense that physicians themselves were a little tweaky about this and that we might do better to just have a single, one-time, confidential, anonymous, not confidential, anonymous survey, no follow-up, no postcards, no master list, no nothing, so that physicians would be willing to fill out a first run. So I wrote this very pleading letter to go with the survey and said, we're not going to bother you again, we're not going to send follow-ups, we have no idea who you are, there is no identified information, just please fill this out. And we got, amazingly enough, 23%, which is considered remarkable for that particular methodology. Moderate to severe depression scores in the PHQ-9, which many of you probably know, 11% only roughly half of which, a little less than half of which, were ever diagnosed. About a quarter of physicians knew physicians who were compromised by their depression. And then we just did some comparisons of physicians with moderate to severe depression scores compared to mild to no depression on the questionnaire. And physicians with moderate to severe depression scores were 2 to 3 times more likely to report difficulty with their responsibilities, significant stress, decreased work productivity and satisfaction, working harder to overcome depression, again, a theme. Physicians with moderate to severe depression scores 2 to 3 times more likely to avoid seeking care due to privacy concerns and stigma, 2 to 3 times more likely to prescribe their own antidepressant, 2 to 3 times more likely to seek care outside the community, to pay cash so it doesn't show up on their insurance, and to not seek care due to concerns about privileges or licensing. So clearly there's a signal in here somewhere about what physicians who are depressed feel about being depressed, and their behavior, at least their endorsement of these behaviors, is significantly different than physicians who had low depression scores. Looked a little bit at community size to get at that. Physicians in communities of less than 10,000 population compared to physicians in larger communities, 250 to 500,000, more likely to prescribe their own antidepressant, 2 to 1, more likely to fear losing their privileges, 2 to 1, more likely to fear losing their license, 3 to 1. So there's a sense of vulnerability, there's a sense of exposure, there's a sense that physicians in smaller communities have a lot to lose if they identify and seek care. Now, that gets me to where I wanted to end and focus, and hopefully hear, especially from medical students, about some of these data. This is a study we did at Michigan. It's a cross-sectional study, web-based. It had follow-up, so we gained approval to do this on a confidential as opposed to anonymous basis. But I'll tell you how we did this. We contracted with a survey research firm as a firewall, and we publicized this intensely because I was obviously very visible in the medical school as a department chair. I'd been there forever and knew students. And we had to make clear that we knew nothing about these responses, that the responses went to a survey research firm, they were confidential to the firm, and then they were de-identified and sent to us for analysis. So they were anonymous to us, and we just pushed this hard, really, really hard, to get the kind of response rate. And this is what we got, was 66%, which in this kind of work is considered unbelievably great, which is more or less how we got this study into JAMA. Moderate to severe depression, 14%. That's a typical number, so we think we got the right data here. Women, twice that of men, which is typical. Cumulative prevalence of suicidal ideation, 22 students from first year through fourth year, 4.4%. That's pretty typical. Suicidal ideation more prevalent in the third and fourth year, like we've already talked about, up to 8% lower in first and second year students. Talk a little bit more about some of the methodological issues, just because this is such difficult work to do. We've already noted that this is a single school survey. We always have those problems. It's very hard to do this work across schools. It's so labor intensive and so time intensive to go to classes, to remind students, to ask for participation, to send email reminders, to go to their lectures, to ask to pop in just before a lecture starts, to go to at Michigan there's a third-year lecture series on Friday afternoons, to go to that and remind students. It's very hard to do that at somebody else's school. So if you compare students with moderate to severe depression scores to students with no or minimal depression scores, 53% of severely depressed students reported that telling counsel would be risky, compared to 70% of those with low scores. Admitting coping skills were inadequate, 62 versus 34. Being depressed makes me feel less intelligent, 46 to 21. Unable to handle responsibilities, respect opinions less, meaning that students who were depressed felt like others respected their opinions less. 56 to 24, and then look at this. I would see treatment for depression only half compared to those who. So students with no minimal scores said, well, of course I would see treatment for depression. If you're actually depressed, you're not likely, which is upsetting, given all the. Exceptions of depressed students by gender and class year. So first and second year students are more likely to agree than third and fourth year students that depressed students are dangerous to their patients, that seeking help would make them feel less intelligent, that admitting depression means that the coping skills are inadequate, that depressed students provide inferior treatment. These are really provocative data, because what it suggests is that first and second year students are actually more critical and less tolerant and more harsh about being depressed. The third and fourth year students, you're starting to get some clinical exposure. So in a sense, you'd say, well, that's good, and that third and fourth year students are starting to see the issues here. Yes, I think it's good, but look at the kinds of students and the opinions who are coming in. It's very tough to start with those kinds of opinions. And male students are more critical. More likely to agree that female students, that medical students would not want to work with a depressed student, and that depressed students are dangerous to their patients. So, I mean, these are just a couple items out of 27 stigma items, so it's not huge, but male students are a little bit less tolerant than female students. So finally, in a second analysis that we're about to publish, we backed up and did a very complex factor analysis to look at the responses and to see how these responses cluster relative to the perception of being stigmatized. So we wanted to see all these different items, how do they sort of hang together. We got pretty good explanation. Almost half of the total variance in stigma scores came from these 5 factors. And these are not surprising, but they do sort of confirm what people have always believed. First factor, which was the strongest predictor of variance in response, was that depression is a personal weakness. And we know that that's an issue with patients. We fight that all the time in terms of depression, meaning an inability to cope, and that it's something you could control if you would just kind of get over it. Second factor was depression causing significant social and professional discrimination, in the sense that students were strongly discriminated against. And then thirdly, kind of related but not quite the same thing, is the devaluation. So discrimination is one thing, devaluation is a different thing, in terms of depressed students feeling less worthy of the attention of their faculty members, less worthy of being taught, less worthy of being in school. Just a sense that being depressed made them not as worthwhile individuals as non-depressed students. A few items loaded here in terms of perception of others, that depressed students were of lower quality in their performance. And then finally, the need for secrecy, which is something we've known for a long time. So there are a lot of research implications of these data. I won't go into that, but I do want to talk about educational implications and clinical implications. I think what is happening here is that all the work we've done with patients and all the attention that we focused on destigmatizing depression in patients, destigmatizing depression in the general population, has yet to get to physicians. Physicians say, well, that's fine for all those folks, but I'm still not willing to accept medical students who are depressed or physicians who are depressed, and I still think that they can just get over it, and that they're not as worthy of attention, not as worthy of treatment, not as worthy of energy. So we somehow have kind of helped a bit with patients being less stigmatized. So now patients will come in and talk to us as primary care physicians about depression when they wouldn't do that 20 years ago. But physicians still feel stigmatized. So we need a whole new approach to all of this. And I just threw out some ideas here. I think a lot of this is an issue of role modeling. It's an issue of professionalization. It's more attention to how are physicians people just like other people, and how do they deal with their lives, and how do they deal with illnesses, and how do they deal with all of the complexity of life, and how could we give them some role modeling around that? How could we show them how other physicians have dealt with this, testimonials, ways that physicians have coped with not just depression, but all kinds of impairments and disabilities and illness over time, and how do physicians manage their life? I think that we have portrayed to medical students kind of this idealized notion of a physician who's always available, always perfect, always compassionate, always smart. And students think, how can I possibly compete with that? And so it causes them, when they do feel inadequate, to just kind of turn in and just say, well, it's my fault. Obviously, that's something I should cope with. Everybody else seems to be coping just fine. Not true, but that's what they see. How could I just kind of take charge of this and take care of it? So I think there's a lot we have to do in terms of curricular issues, professionalism issues, in the way that we deal with this. But I would have this caveat, which is be careful about unintended consequences. So when these data came out, when the study came out in Jan, it was in the fall. First year class was ramping up. Michigan has a position in society, small group kind of thing, like a lot of schools do. And the director of that course was so excited. Said, "This is an amazing study. Congratulations. We want to use these data. We're going to have this as a topic for discussion in the small groups, and we want to have students talk about depression, talk about their mental illness, talk about coping, talk about stress." I said, "Whoa, whoa, whoa. Take a break here for a moment. And you're about to open up some really potentially very damaging, very toxic issues here. And to do that in just random small groups, some of whose leaders I'm sure are fine, and some of whose leaders are probably not so fine, and just have students expose themselves to potential further stigma before we have figured out what to do with this is not a great idea." So they backed up a bit. We had some more general discussions. I made some presentations to students. We had some very productive presentations with students and some time to talk afterwards. The students would start to open up, but that was their choice, and it was in a fairly protected environment. And it was pretty powerful, I think, when I did this with all third-year students last year. So we just have to be careful. My point is how we go about this. Clinically, I think the main issue is we have to be available to our peers and to our colleagues, and we have to learn how to be available, to be collegial, to say that if someone is clearly having difficulty, if someone is clearly not functioning, someone is clearly withdrawing, depressed, kind of bitter, edgy, not themselves, that it's our responsibility to step up and do something about that. Is it going to be easy? No. When you start to talk to colleagues about this and say, it seems to me that you're not doing real well, you get hit pretty hard most of the time, because physicians are really good at pushing back on that. So it takes a lot of persistence and a lot of compassion and a lot of help. And I think we have to develop some new approaches here. Physicians are not like other patients. We know things. We have responsibilities. We have prestige. We have roles. We have visibility. It's not the same as taking care of just general patient populations. And so we do have to develop some new approaches. So I think that we have to think about this and how we respond to each other, how we respond to our colleagues, how we respond to the wider world. Just a few little warning signs: changes in behavior, less interest, isolation, longer work hours, less efficiency, deterioration, mood swings. Alcohol is a big issue. We all know these things. There's nothing special about this. But we tend to ignore them in physicians. There are things that you will see in other patients that you, or other friends even perhaps, or family members that you would jump on. You see it in physicians, you go, "Oh, well, not my business." It is our business. Just a couple of resources from AFSP, which is a big organization very involved in this work. And most states have impaired physician programs, and there's some pretty good programs in some states for this that you can reach out to. So here we are. Depression is common, especially in women. Risk of suicide is higher than in the general population, especially in women. Depression is powerful. It has huge impact on physician practices. It causes tremendous social and professional disruption. And stigma is huge. It lags way behind stigma reduction in patients. I think there's still a conspiracy of silence. I think we're still not willing to really deal with this, not willing to talk about it, not willing to step up and take care of our colleagues like I think we have the responsibility to do. So lots of ways we can think about this from an educational and clinical perspective, but I think it has to do with us. I'd be very interested in your comments, your reactions, especially from students as you look at some of these data. But I hope you'll take some of this away and talk with your colleagues and think about things you might do here in Louisville to help this. Thank you. We have time for a question or two?
5 minutes or so. If you have a question, I'd like to direct Dr. Schwenk.
Thank you so much.
I'm sorry, we're going to get each other. I'll let you moderate. Go.
Thank you for bringing attention to this issue. And I had a question about role modeling. And I wonder if you think that role modeling or the solutions to these problems are the same for physicians who are in practice versus resident physicians versus medical students. And I'll just give an example that I work in an interdisciplinary team with chaplains, psychologists, and other professionals who I think are much better role models to me than my physician colleagues in terms of self-care and work-life balance. So, but I don't know if that a medical student would see that role model as maybe legitimate. So I wondered if you could comment on, on that.
That's a great question. Start at the top. I think physicians probably do best with very personal interventions, a close friend, a partner, a colleague. It's got to be very private, very close. Residents, I think we know nothing about residents. There's going to be a bit more coming out, I think, that'll be of interest. There's a psychiatrist in Michigan with whom we've collaborated a bit, named Srijan Sen, who is doing some interesting work in more longitudinal work following medical students into residency. And he's thrown in some genome work looking at serotonin transporter genes, doing some salivary cortisol, a few interesting biomarker things. But the best part that he's doing is following residents over time, and that might start to help us understand a bit what goes on with residents. But I think that residents are probably going to fall more into the medical student side than into the physician side. And that is, I think residents and students both need and so respond to role modeling and to seeing how more senior physicians have dealt with this. And I think they can cope with that on a group basis to some extent. So I would imagine, for example, for students, that if we could develop some teaching programs in which a senior physician is very self-disclosing and very revealing about their experiences and how they worked through this and how they are now the functional physician that they are, I think that would be very compelling. Residents maybe are in the middle in the sense that they maybe still need a little more privacy, they may be a little vulnerable. Students, I think, are a little more willing to open up a bit and to hear about this on more of a group basis. But in answer to your basic question, I think it mostly is going to come back to physician role model. I think physicians are so strongly imprinted on other physicians, and medical students and residents are, that other disciplines, you mentioned several, can be intellectually helpul, but probably not as emotionally or personally as helpful as a medical student sees a physician and says, I want to be like that.
Okay.
I think there's a very strong imprinting that goes on there.
Has the limiting of duty hours that happened, I forgot when that happened, had any impact, do you think?
We don't know much because, again, we've studied this so little in residents. My gut sense is no. And you'll be sorry you got me going on this, but
9 years. It was 9 years.
My problem with the whole duty hour thing is what we basically said is life as a resident really sucks, and so we're just going to reduce the dosage instead of actually dealing with why it sucks. And talking about team care and support and handoffs and how it is that if you're feeling sick or you have a personal emergency, you can call somebody for help and you don't get blasted for it. It's those kinds of things that we've done nothing about. No communication techniques. There are starting to be some new studies looking at handoffs and sign-outs and how you communicate and how you can get more of a team-based approach. But it's very primitive. And what we basically said is we don't know what to do, so we're just going to make you do less of it. Which I think is really not a good approach.
Good answer.
And what it does do is, of course, you have unintended consequences. What you now have is the residents going home at night and the attendings in the hospital all night saying, where are my work rule hours? There are concerns that residents are not being adequately trained because of the reduction. There are concerns in surgical disciplines that there aren't enough cases, that they don't see the follow-up, they don't see what happens. I had the chair of surgery at Michigan, who's a good friend, tell me a story one day that he and the chief resident had seen a case Saturday morning, and they'd operated, and then the chief resident leaves for the rest of the weekend because of some duty hour thing, or he was on a trip or whatever. the attending, the chair of the department, carried the patient through the weekend. The chief resident comes in Monday morning and says, "Oh, hi, chair of the department. How's our patient doing?" And the chair of surgery just about exploded. How is it that we got ourselves in a situation where the chief resident doesn't know what happened to the patient over the weekend? So I understand that life is demanding. Medicine is way different than it was. See, old farts like me shouldn't be making these decisions, because when I was an intern, life was very different. Medicine was a lot simpler, a lot less intense. So we need to understand how intense it is and how can we design communication programs and team care programs and other ways so that people can learn and still have a reasonable life. And we haven't done any of that yet. See, I'm just sorry that you got me going.
Next more question, then let's go.
I kind of wanted to build on that in the sense of that the intrusive monitoring in that narrative that you read. What was the procedural justification for that? What was the policy justification for that?
For which?
That intrusive monitoring of, you're going to be on probation and we're going to have to check on you every 3 months. Yeah, in the case that you read?
There's a huge problem. It's getting better. This probably goes back to the early 2000s, I think. And since then, things have gotten a little better with some of the state licensing boards. But there are many data from the 70s and 80s on into the 90s, being a little better in the 2000s. The state licensing boards had the power to be exactly that, intrusive. And medical staff committees, this was an executive committee of medical staff, did the same thing, which was to label these physicians as damaged, as impaired, and to require that kind of monitoring. And I've actually sat on medical education boards and had these discussions, and I said, don't focus on the diagnosis, focus on the performance.
Right.
If there's no performance issue, then you have no right to get into someone's medical or psychiatric history. But we treat mental illness differently. And part of it is the invisibility issue. If you have a surgeon whose wrist is broken, it's pretty clear when they can't perform and when they can perform. Depression is harder, and I understand that, but you still have to focus on the performance, not on the disease. And there was no evidence, I've dug into this a fair bit, there's no evidence that he was impaired in his performance. But he had a label. And the label caused them to be allowed, probably not legally, to request those kinds of records. Everybody said, oh yeah, that's okay. Probably not. Yeah, that was a downbeat way to end. But
Dr. Schwenk has presented a fascinating subject that is important to all of us, and I'm sure the discussion will go on. We go now to the residents and see what cases they. Thank you for being here.